Welcome to this webinar on World Stop Pressure Ulcer Day. My name is Professor Zena Moore, and I'm head of the School of Nursing and Midwifery and director of the Skin, Wounds and Trauma Research Centre at RCSI University of Medicine and Health Sciences. And I would like to introduce to you the speakers for today's webinar. Dr. Aglecia Budri, who is a lecturer and programme director of the Wound Management and Tissue Viability Programme. And Aglecia is also a lead researcher at the SWaT Centre at RCSI University of Medicine and Health Sciences. And Natalie McEvoy is a PhD student at the SWaT Research Centre at RCSI University of Medicine and Health Sciences. And Dr. Pinar Avsar is a postdoctoral researcher in the SWaT Research Centre at RCSI University of Medicine and Health Sciences. And we're going to cover a number of topics with you today: pressure ulcer etiology, risk factors, mobility and activity, skin assessment, and repositioning. And this will be followed by a live question and answer session. So I'm really delighted that all of you have joined with us today so that we can collectively contribute to the World Stop Pressure Ulcer Day. Thank you very much.
Hi everyone, my name is Natalie McEvoy and I am a PhD student in the School of Nursing and Midwifery in RCSI. And I'm here today to talk to you about pressure ulcer etiology. We'll begin by defining what a pressure ulcer actually is. So a pressure ulcer is localized injury to the skin and or underlying tissue, usually over a bony prominence, as a result of prolonged mechanical loading in the form of pressure or pressure in combination with shear. In order to develop a pressure ulcer, an individual must be exposed to external mechanical loads, pressure, and or shear, and increased skin temperature and humidity, so adverse microclimate, all of which cause tissue deterioration. There are a number of contributing factors associated with pressure ulcer development, and the primary factor is immobility. There are many known risk factors that shorten the length of time that the tissue can withstand immobility, including poor perfusion, diabetes, incontinence, skin status, and nutritional status as well. So there are two main approaches to pressure ulcer development then. So we have the top-down approach, and this involves pressure and shear damaging the skin surface and or the upper layers of the subcutaneous tissue. Meanwhile, the bottom-up approach occurs where we have suspected deep tissue injury, whereby you've sustained pressure and a resultant strain on the muscle between the external force and the bony prominence. So there are differences in the etiology of superficial pressure ulcers when compared with pressure ulcers that are deep in the tissue layers. Superficial pressure ulcers are predominantly caused by shearing forces, and deep tissue injury are as a result of sustained pressure and or shear. So there's two major damage pathways for pressure ulcer development. And firstly, ischemia. So this can happen with or without reperfusion injury. So when we talk about ischemia, we have this sustained pressure on an area. There's impaired perfusion to that site. There's a subsequent decrease in oxygenation, so that will result in altered metabolism and an accumulation of toxins or waste products. There's then an alteration in pH and resultant cell death. We've kind of mentioned that this can happen with or without reperfusion injury. And so what actually happens? What do we mean when we talk about reperfusion injury? And what happens is we have a prolonged episode of ischemia, and we then have reperfusion to an area. And with that reperfusion, there's a release of harmful oxygen-free radicals and pro-inflammatory cytokines, and this can actually increase tissue damage. So we then talk about cell deformation. So what happens? We sit on our tissues, and within our tissues we have cells. So the cells become distorted, and we have damage to the structures of that cell as well. So when we have cell deformation, there's cytoskeleton disruption, increase in vascular permeability and cell membrane failure. We have an alteration in homeostasis, and again, then we have this cell death. So both of these processes have the same end result. They both result in cell death. However, the major difference in these pathways is that ischemia can happen over hours. However, cell deformation is a much quicker process and it can happen over minutes. So quite a difference there. I've included this image that I just think is a really nice visual representation of what's happening to the tissues and the stress that the tissues are under in response to sustained pressure over a bony prominence. So we move on then, and we're talking about these physiological processes that are happening and that result in pressure ulcer development. So what's really interesting is if we look at what's happening beneath the skin surface, there's a huge amount going on that we can't see. So we have what we can see here is manifestation threshold, and this, I suppose, is our current gold standard of pressure ulcer detection is visual skin assessment. And this is where we examine the skin and we can see there may be visual skin changes such as redness, or there might actually be tissue rupture, which will happen in our stage 2, 3, 4 pressure ulcers. And then there might be tactile changes as well, so there could be heat, swelling or pain at the site. But look at all of the processes that happen before we reach this manifestation threshold. So wouldn't it be ideal to detect the damage before we can actually see it? And is there a way we can do that? So this is when it's really interesting then when we talk about this manifestation threshold compared with the damage threshold. So we've mentioned what the manifestation threshold is, and it's the point at which damage is apparent at the skin surface. However, in contrast to this then, we have this damage threshold. Now the damage threshold is a point at which an objective test of physiological changes below the skin could reveal early damage that with intervention could actually result in pressure ulcer prevention. So we have subepidermal tissue damage and interstitial fluid accumulation, and we've got the subepidermal moisture here, and that we're going to talk about in more detail now. But this damage is actually occurring 3 to 10 days before manifestation. So we talk then about tissue injury threshold. And the tissue injury threshold is this transition from microscale reversible damage that usually occurs at cellular level to macroscale irreversible tissue damage, which is visible, and that may be visible by imaging, such as ultrasound or MRI if it's subdermal, or it might even present itself on the skin surface. Subepidermal moisture then, so we've just mentioned. Now, in the early stage of pressure ulcer development, there's this inflammatory process triggered by tissue injury, which results in an increase in blood flow to an area, causes fluid accumulation beneath the epidermis. And this accumulation of fluid below the epidermis is known as subepidermal moisture, or SEM, with increased vascular permeability, allowing fluid to enter the extravascular space, which leads to a buildup of oedema. And this is not visible to the naked eye in the initial stages. So what can we do? Can we detect this damage before, or do we wait for these kind of macroscopic signs of tissue destruction to appear? Well, we do have the subepidermal moisture scanner, the SEM scanner. So this was developed by Bruin Biometrics. It's a handheld portable device. The moisture level of subepidermal tissue is measured through the use of an electrode structure that you put on the surface of the skin, usually over a bony prominence, such as the sacrum or heels. There's then low amplitude signals that use surface electrical capacitance to assess the level of fluid or edema in the subepidermal tissues, epidermal or subepidermal tissues. And as we've mentioned, this fluid is part of the inflammatory process that's happening when pressure ulcers are forming. The SEM scanner aims to detect early signs of pressure damage before they become visible to the healthcare provider. And in contrast to our current gold standard, that is visual skin assessment, the SEM scanner detects the early phase of microscopic cell death by detecting SEM changes, rather than waiting for these macroscopic signs of tissue destruction to appear. So what do we know about SEM to date? Well, there's been a huge amount of research into this. So we have recently completed a systematic review that just compiles all the evidence that's available to us to assess evidence around measuring SEM to detect early non-visible pressure ulcer development. And it's been submitted for publication. It is not yet published. But the primary outcome of this paper was to determine the validity of SEM measurements to detect early pressure ulcer development. And there were a number of secondary outcomes then, so time to pressure ulcer detection, sensitivity, specificity of SEM measurements, and then the impact of these SEM measurements on pressure ulcer prevention. Interestingly then, in all of the included studies, so there were 17 studies conducted from 2007 to 2020, there was an abnormal deviation in SEM measurements corresponding with evidence of visual pressure ulcer development in all of these studies. And the key finding of the review was that SEM measurements could detect pressure ulcer development sooner than visual skin assessment at a mean of 4.83 days earlier. So we move on then to talk about cytokines. So cytokines are a very promising method to monitor tissue status involves non-invasive biomarkers. And these cytokines are synthesized and released when we have mechanical injury to skin cells, and that's what makes them a biomarker. Interleukin-1 alpha or IL-1 alpha is just one example of a pro-inflammatory cytokine that's released when you have injury to keratinocytes when they're put under pressure. This has been shown to be significantly increased after pressure loading of the skin. And there is a way to simply measure or to collect sebum from the skin surface using SWaT. And the SWaT then, you perform laboratory analysis, and you can then look for pro-inflammatory cytokines, including interleukin-1 alpha, among others. So a number of studies have been conducted to determine the presence of interleukin-1 alpha in these areas that are undergoing pressure and shear using these tapes, extracting sebum from the skin. And what's problematic is that the vast majority of these studies are conducted in a laboratory setting among healthy volunteers, and there hasn't really been a whole lot of research into a sick population of people, and it hasn't really been tried and tested in patients. So this brings me on then just to very quickly mention some research that's currently underway in the RCSI Skin Wounds and Trauma Research Centre. And my own PhD study sets out to determine this correlation between the pro-inflammatory cytokine interleukin-1 alpha, total protein, and SEM measurements in the early detection of pressure ulcers in adult intensive care patients. And one of my colleagues then her study sets out to determine this correlation and agreement between SEM measurements, epidermal hydration, temperature, pain, and ultrasound in the early detection of pressure ulcers. So there's a huge amount of research ongoing. So we've discussed the processes involved in pressure ulcer development and how we can detect these processes or these changes early. And when we do detect pressure damage, signs of pressure damage early on, well, what can we do? Because there is a huge amount that we can do. We can increase our preventative strategies by way of frequency of repositioning, offloading devices, preventative dressings, that's just to name a few. So I have just left you with some references here and a take-home message that is prevention is key. Thank you for listening.
Hi, my name is Aglecia Budri. I'm a lecturer and program director at the Royal College of Surgeons in Ireland, and this presentation is entitled Excess Movement and Too Little Movement, Two Sides of the One Coin. And it's a result of my PhD studies where I set out to better understand activity and mobility and how it influences the development of pressure ulcers. But first I want to define what is movement, what is activity, what is mobility. And mobility is the ability of a person to make postural changes to dislocate or change orientation. And movement relates to the frequency or the magnitude of these postural changes with which can be self-induced or induced by a staff member. However, activity assesses mobility in a macro level, so think of what is the person is able to do with this level of mobility that you assessed beforehand. So the person can be, for example, bed fast, chair fast, walk occasionally, walk frequently, need helps to walk or walk independently. So this all gives you an idea what the person is able to do with the mobility they have. But you can also think of mobility as being an assessment which gives you the information on the length of time an individual will be exposed to pressure and shear. A bedfast individual is exposed for longer periods of time to pressure and shear than an individual who walks frequently, for example. But the confusion really starts when we look at the research done on those two concepts, okay? And when we study etiology of pressure ulcers and how the recommendations from the current 2019 international guidelines were based upon, immobility seems to be the factor that leads to pressure ulceration. In other words, most of the research done in the past points us to the idea of immobility being the pressure ulcer causal factor. From the 2019 guidelines, in the evidence summary, you can see here called activity and mobility limitations as a risk factor for pressure ulcer development in adults, we can see that the first recommendation highlighted below is actually based on 55 studies, diagnostic studies that included factor associated with immobility in their module. Therefore, when studying pressure ulcers etiology and reading paired mobility, immobility is naturally associated with the problem. And for this reason, when we first started this particular study, we aimed to identify how activity and mobility led to pressure ulcer development using assessments for mobility, a movement sensor, and early pressure ulcer detection to be able to detect small changes in the skin status. Our main goal was to explore how activity and mobility, along with other risk factors, led to pressure ulcer development in older persons cared for in long-term settings, and we included 150 patients at the time. However, what happened was their movement data was so hard to make sense that we needed to have like a standard to be able to compare their data and make sense of it. So what we did, we decided to explore mobility in healthy volunteers using the same piezoelectric sensor we used in the older adults in order to understand how healthy adults moved and then compare to our older patients. And here is just a quick overview of our data collection for our older patients over the period of 20 days. And as you can see, we checked their skin using both visual skin assessment and subepidermal moisture assessment every day, while their movements were being recorded continuously. Just a quick explanation on SEM assessment linking with the previous session you watched on biomarkers. This subepidermal moisture assessment is a biophysical marker and is a product of the leak of plasma after inflammation process increases local vascular permeability. SEM starts as a microscopic edema growing into a macroscopic scale, becoming then detectable on imaging and examinations, and only at very later stages with the naked eye. So first, you can see signs of inflammation using assessment methods such as cytokines and the subepidermal moisture assessment. And we decided to go ahead with the subepidermal moisture assessment at the time to be able to identify those small changes that indicated pressure ulcer damage. But moving on with our findings, and in regards to mobility assessment, what we found was that our older participants' movement score varied substantially from close to 0 to 500 movements per hour. When we first started our study, we expected that we would be able to set a threshold where we could state, okay, patients doing less than this amount of movement per hour are developing pressure ulcers, and patients doing more than this are safe. However, that didn't happen. And even patients with high levels of mobility, they were developing pressure ulcers, which is totally unexpected. Comparing the healthy adult participants, the movement values for the older persons had a much higher variance. And in addition, the median number of movements per hour of the older persons was almost half the median number of movements per hour performed by our healthy adults. As expected, participants with low frequency of movement were developing pressure ulcers, but participants with high level of movements were also developing pressure ulcers. And that's why we separate them into two groups: the low movers, those prone to immobility, and the high movers, those prone to agitation. On that note, another alarming finding was that 19% of the participants were classified as being immobile according to the Braden scale, but were actually doing lots of movements, as they were classified as high movers according to our movement center. And maybe because those participants were bedbound or were doing such small movements that the observer could not detect, which led to this percentage of misclassification. And it is highly relevant result that almost 20% of the participants were misclassified as being immobile when they were actually doing lots of movements, and that may change their preventative measure needs. And my next slide is also interesting because it shows the incidence of pressure ulcers using both visual skin assessment and subepidermal moisture assessment. As visual skin assessment is able to assess skin, only the skin surface, we had a much lower pressure ulcer incidence than compared to what we called sand pressure ulcers. And by that we meant 3 or more days of consecutive abnormal subepidermal moisture deviation, SAM deviation. What is interesting is that both assessments were in agreement that our low movers and also our high movers were both developing pressure ulcers, and with very similar proportion between them. And from those results, we believe that there are some participants, depending on their overall mobility status, they have a more static or a more dynamic problem influencing the pressure ulcer development to them. To understand the possible explanation for what was happening, we had to revisit the literature, especially with studies published by our engineers colleagues. And from the literature, we know that in static conditions, pressure forces to the bony prominences may link to tissue damage by pressing the tissue layers down. And this causes occlusion of lymphatic and blood vessels, slowly leading to ischemia and ischemia reperfusion damage. Another possibility is when under increased loading conditions, cell deformation may occur to the point that deformation exceeds normal physiological values experienced in daily life. And this causes direct deformation damage, which cell death occurs quickly. However, in more dynamic conditions, when a mobile patient with low coordination is trying to move in bed, and in doing so, it drags the bony prominences over the supporting surface, shear forces may be more important. If an individual has the ability to make even small movements, there is some pressure related to the bony prominences. However, these individuals may not necessarily move into a safe position. Alternatively, the lack of well-coordinated mobility results in dragging of the body on the bed surface, causes high friction and shear forces, which acts on the tissue over the bony prominence. And then looking at those findings, our clinician side made us go ahead and do these theoretical cohort-based recommendations for pressure ulcer prevention. We believe that patients with different movement status need different prevention approaches. So we separate them into 3 cohorts depending on their activity mobility levels. So the first cohort are the low movers who are also bed fast or chair fast. And we recommend the use of pressure redistributed surfaces and enhanced reposition because these individuals spend a long time in bed and have low levels of mobility. The second cohort are the high movers who are also bed fast and chair fast. As with the first cohort, these individuals also need pressure redistribution surfaces because they spend a long time in bed or sitting in the chair, but when they are in bed, they are not necessarily making safe movements. And because they are agitated, repositioning may be a challenge with this cohort. Additionally, there are high levels of movements resulting in the normal temperature and moisture conditions. Therefore, microclimate management through the use of appropriate textiles and adequate supporting surfaces is also recommended. And finally, the use of dressings to protect bony prominences may be beneficial to them, to all high movers actually, as shear forces may lead to superficial pressure ulcer damage. And our third cohort are those with higher levels of activity, such as those that walk occasionally or frequently, but were identified as being high movers in bed. And microclimate, and we need to address the microclimate, so avoiding the extremes of temperature and moisture, and they may benefit as well from the use of dressings to protect their bony prominences. However, there may be no need of repositioning, and there's a need of careful use of pressure redistribution surfaces, as these individuals are at high risk of fall. But to conclude, despite of the limitations, what is clear is that pressure ulcer occurs commonly among the older population, and traditionally low movers have been identified as those who develop the problem. However, what has been identified in this study is that those who are agitated, as well as those who are low movers, have problems in terms of pressure ulcer development. So the question I want you to think about to end this presentation is, can we still rely on what we visually see or subjectively score in terms of movement and skin damage? I hope not. So thanks for watching. I invite you to join us in the Q&A section. Thank you.
So welcome to the lecture on skin assessment, and my name is Professor Zena Moore. So what I'm going to discuss with you is why we do skin assessment. Why are we interested then in subepidermal moisture measurement? What does the literature say about SEM? our experience in undertaking research in this area, and then a little discussion about where we should go to then. So when you look at the 2019 Prevention and Treatment of Pressure Ulcers guideline, when they discuss conducting skin and tissue assessment, they advise us to conduct a comprehensive skin and tissue assessment for all individuals at risk of pressure injuries. And they say we should do this as soon as possible after admission or transfer to the healthcare service, as part of every risk assessment, and then periodically as indicated by the individual's degree of pressure injury risk and prior to discharge from the care service. So they're advising us that the undertaking of a skin and tissue assessment is important in the care of individuals at risk of pressure ulcers. So when we're doing this assessment, we usually use our eyes. So it's visual skin assessment, and we use staging systems. And the problem is that the staging systems are often misinterpreted because the main focus is on the skin tissue, the outer skin tissue, even though the underlying muscle tissue may actually be more susceptible to changes in perfusion than because of mechanical loading than is the skin. And the challenge is that damage more often is occurring in the deeper layers and emerging outwards towards the skin. And if we're relying on skin assessment alone, we will not be able to see that. We will only be able to see what's on the skin, not what's happening underneath the skin. And clearly being able to see underneath the skin would be fundamentally important for us to know that there is early evidence of damage like that this patient is experiencing. And if we understood that, we should be able to intervene appropriately. The other challenge is that the reliability of the pressure ulcer grading systems that we use, when we look at studies, we can see that the mean reliability is only 0.60. And that means that there's only moderate agreement among clinicians and researchers and educationalists when they're undertaking risk or grading, should I say. And the problem with that is, could you imagine if you were in healthcare and we were looking after you for a particular problem, but we only had moderate agreement among all of the team that's looking after you as to what actually is wrong with you? It wouldn't make sense. So therefore, we need to think about having more reliable methods of understanding what's happening with the patient in response to their exposure to pressure and shear. And I like this because it's sort of saying to us, like, in other words, if you keep doing what you've always done, you'll always get what you've always gotten. Which means that if you're happy enough that we only have moderate agreement about our assessment of individual skin, then we should continue. But clearly, only having moderate agreement is not good enough for us. So new technology for pressure ulcer detection is needed. And when you look at this picture here, I would like you to look at the area between the two red lines. So what we're talking about is the damage threshold and the manifestation threshold. What that means is that there is a point when you're looking after patients where if you were able to detect that there is damage occurring, early damage occurring in the patient, and if you were able to intervene at that point, you would be able to avoid the patient getting the manifestation of that damage, which is a visual pressure ulcer. So if you look beneath the red line where the damage threshold is, these are the processes that are occurring early in pressure ulcer development. And if we understand and appreciate that these are happening, then we know that our patient is in trouble. However, if we wait until we see something on the skin, it's too late and you can't actually reverse the process. So one of our students, Anna Oliveira, undertook a systematic review looking at the accuracy of ultrasound, thermography, and subepidermal moisture in predicting pressure ulcers. And we identified 4 studies on SEM, 1 on thermography, 5 on ultrasound for inclusion in the review. And the data analysis indicated that photography was not a method which allowed for the early prediction of pressure ulcer presence at all. SEM values increased with increasing tissue damage, with the sacrum and the heels being the most common anatomical locations, as you know, for the development of erythema and stage 1 pressure ulcers. Thermography identified temperature changes in the tissue and skin that may give an indication of early pressure ulcer development. However, the data were not sufficiently robust. Ultrasound then detected pockets of fluid and oedema at different levels of the skin that were comparable with tissue damage. Thus, ultrasound were the best methods for allowing a more accurate assessment of early skin or tissue damage. We didn't have access to ultrasound at this time, but we did have access to subepidermal measurement, and therefore we chose to explore this a bit further. And so the international literature identifies that higher SEM scores correspond with increasing pressure ulcer damage. And abnormal SEM is predictive of concurrent and future visible pressure ulcer damage 1 week later. And intervening when abnormal SEM delta enables focused preventative strategies to be implemented, and it reduces the incidence of visual pressure ulcers. So when we're talking about abnormal SEM deltas, the SEM delta is the reading that looks at the difference between the lowest and the highest reading from a number of readings taken over an anatomical area. And we're looking for readings of 0.5. The international literature looks at 0.6. So anywhere between 0.5 and 0.6 we consider to be abnormal or higher. So we've completed 7 studies. 2 of them are in acute care surgery, 2 of them are in medicine, and 3 of them are in long stay. So in this very first study, we were interested in looking at the relationship between risk assessment tools and subepidermal moisture measurement. And what you can see in the graph on your left-hand side is that we recorded Waterlow and Braden scores for 4 weeks on 29 older persons. And what you can see is that their Waterlow and Braden scores didn't change at all over the 4 weeks, which would indicate that these individuals were considered to be stable. But if you look at the graph on your right-hand side, you can see that the SEM deltas varied, as you would expect, due to changes in tissue health and interventions that are applied for the patients. 3 of the participants developed a pressure injury, indicating a pressure ulcer incidence of 9.5%. Now, what we found interesting about this was that you would expect that SEM deltas would change in all of us, depending on how long we're exposed to pressure and shear, and depending on how often we reposition. So what we found was that the SEM deltas were able to tell us more individually and uniquely for the patient, their individual responses to pressure and shear, which if we had had a sustained SEM that had developed in people, which you see in the pressure ulcer incidence, then ideally we would be intervening in order to reduce that. So what the Waterlow and Braden is not telling us is individual changes in that patient on a daily basis that the SEM deltas enable us to detect. So then we moved on to look at acute care and surgery, and 31 patients were followed up. And what you see here, if you look at the graph on your right-hand side, is that as you would expect, as the person walks in to the hospital, their SEM deltas are normal because they're mobile and they're not exposed to pressure and shear. Whereas when they're immobile due to surgery, you see the SEM deltas elevating. And then as their mobility decreases because they're back up and about the place walking around, then their SEM deltas decrease as you would expect. There was a pressure ulcer prevalence of 6%, whereas the SEM detected 42%. And what we found was as immobility increases on the day of surgery, elevated SEM deltas were recorded. And as I said, as SEM deltas decreased because of the remobilization. So in this third study, then one of our MSc students, Gillian O'Brien, undertaking her MSc in Advanced Practice at RCSI University of Medicine and Health Sciences, looked at the relationship between nurses' visual assessment of the skin and subepidermal moisture measurement. Acute care, 47 patients followed up for 20 days. 62% were female with an age of 74.7 years on average. And 34% of them developed signs of early pressure ulcer damage. And the mean number of days for this to become obvious to nurses on the skin was 5, whereas the mean number of days that SEM had detected this damage was only 1.1. So SEM measurement identified early damage 3.9 days before the nurses did. Now that is significant. Now in this study, we were not intervening, we were only observing. And if it was possible to intervene, we may well have been able to reduce the number of individuals that had developed the visual signs of pressure ulcers, because the SEM measurement detected changes in the patients that were important at 1.1 days. So then Anna, who I introduced to you previously, undertaking her PhD, looked at the role of subepidermal moisture measurement versus traditional risk assessment in the prediction of pressure ulcer risk among adults undergoing surgery. She followed up 228 patients for 3 days, for those who remained in hospital for 3 days. 55.8% were male, with a mean age of 85.6 years. 53% undergoing orthopaedic and 47% undergoing general surgery. The mean duration of surgery was 88.4, with a pressure ulcer incidence of 51% due to SEM and 3% due to visual skin assessment. Now, I think what you can see here is that if you look at the table here, was that on day 1, 98% of the people had an abnormal delta, which would make sense to us if you have had a period of prolonged immobility during surgery. And the number that were followed up were less on day 2, 114 as opposed to 225. And what you can see is that still, of those who are followed up on 2 days post-op, 97% of them had an abnormal delta. And then 62 were followed up for 3 days and 94% of them had an abnormal delta. Now, what that means is that the undergoing surgery is a major risk, regardless of what type of surgery you're having or the duration of surgery. It is a risk environment for the development of early pressure ulcer damage. Now, why that's important for us is that if you and I were able to know that an individual had an abnormal SEM delta, say on the left heel or the right heel, you would be able to target interventions to ensure that that individual did not have prolonged exposure to pressure and shear over that area that was showing you, due to the SEM readings, that they had already early damage. Because we know from the literature, from the studies done in animals and humans, that the body is able to tolerate pressures for a period of time, but after a certain period of time, the damage potential increases rapidly. So the more that you have pressure and shear over an already damaging area means that you inevitably will get a visual problem unless you intervene early. And then Aglecia, who you have met today, looked for her PhD looking at pressure ulcer risk assessment, risk factors and risk screening in older persons. So 150 whom she followed up for 20 days, 74% were female with a mean age of 84.3 years. She was recording movement, and the mean movement score was 121 movements per hour. She found a pressure ulcer incidence using visual skin assessment of 12% and using SEM of 78.7. Now, I think what's really important here in Aglecia's work is that she found an equal number of individuals developing pressure injury due to being a low mover, as you would expect, but also the same number more or less occurred among the high movers. Now, that was unexpected. And we found the same thing looking at SEM, that the same percentage almost occurred in the low movers as in the high movers. And what Aglecia identified was that the way in which we assess mobility using Braden is not accurate to detect those who have abnormally high movers, who are abnormally high movers. And what she tried to do to understand the difference between what people normally do and what did this population do, you can see in the top figure there, she also recorded movement scores for the healthy adults. And what you can find from that particular box plot is that the healthy adults, we all tend to move in a very similar way. Whereas what you can see in the older persons is that the distribution of the data is massive. So some people are making a huge amount of movements and some people are making almost no movements. And the people in both ends of these spectrums are at risk of skin tissue damage. And the beauty about the SEM scanner was that it enabled detection of this, that the visual skin assessment would not have detected, because you can see from the lower figure, is that the mean difference in time for SEM to detect the pressure ulcers versus visual skin assessment was 6.2 days. So what I mean by this is that, first of all, the Braden scale does not accurately predict or determine those who have abnormally high movements, because normally it's looking at whether you're bed fast, chair first, etc. And also that if we were using subepidermal moisture measurement, we would be able to detect changes in people who are at both ends of the spectrum, high and low, and we would be able to intervene then. And Aglecia has developed an algorithm for how she suggests that we should take care of people who are abnormally movers versus abnormally low movers. But the point we're making is that both ends of the spectrum are at risk of tissue damage. And the beauty with the subepidermal moisture measurement is that it enables us to pick this up, because we wouldn't normally be looking out for people who have abnormally high movements. And the problems are equally distributed between those who are low and high movers. And so what we really want to understand is the category of normal, the category of low, and the category of high. And our current detection systems don't enable that, because in this particular study, Aglecia was using a totally different movement sensor. And then Pinar, who is our postdoc in the Skin Wounds and Trauma Research Centre, wanted to move on from the work of Aglecia. So she was looking at developing an algorithm based on activity and mobility for detecting pressure ulcer risk among elderly residents in long stay. So Pinar followed up 53 patients. She collected the data daily for 4 days. 74% are female with a mean age of 87.5. And she found that 51% were considered to be not at risk or mild risk, according to Braden. The mean movement score per hour was 110, and she identified that 41% were low movers. And as with Aglecia, she identified a similar distribution of abnormal SEM deltas among the low movers and the high movers, exactly similar to what Aglecia had identified. And so what that's telling us is that we really need to start to explore movement and responses to this. So it isn't sufficient just to count movements and say, well, if Zena makes more movements, she's grand, and if Pinar makes less movements, she's not grand. What we really want to understand is low movers, abnormally high movers, they're the people in trouble, and can we identify people who are making a normal number of movements? Because if you look at the graph there in your left-hand side there, you can see the distribution of the data for the movement results for Pinar is very similar to that of Aglecia, meaning that the distribution is very, very wide. Some people are making almost no movements, some people are making an abnormally high number of movements, and that's a problem. And look at what Pinar identified there, with 51% identified as being not at risk or mild risk, according to Braden. But clearly that doesn't capture those who are making you can see from the low movers and the high movers. And so clearly our current risk assessment tools don't enable accurate detection of our patients. And so then this is like the really, really creme de la creme study here, because this particular study by our current PhD, Saoirse Byrne, is looking, Saoirse decided, well, let's see, we know that the SEM is able to detect early pressure ulcer damage. So because we know that now, could we intervene and see what difference that made to visual pressure ulcers, SEM pressure ulcers, and also maybe changes in the SEM scores? Because if it is that the SEM is up an early inflammatory response, by intervening, we should be able to reduce that inflammatory response, and therefore the SEM should be able to detect that reduction in the inflammatory response. So Saoirse undertook a randomized control trial exploring the impact of mobility assessment and subepidermal moisture measurement versus traditional risk assessment and visual skin assessment on pressure ulcer incidence. Acute care, 149 people, 2 groups. The intervention group were assessed using mobility and SEM, and the control group risk assessed and using the normal and Braden and visual skin assessment. And then in the intervention group, depending on the results of the subepidermal moisture, so if it was an abnormal delta, Saoirse intervened with the skin bundle. And in the control group, the nurses waited for changes in the visual skin assessment before they intervened. Data were collected daily for 5 days. 43% are female with a mean age of 67.3. She found for a SEM pressure ulcer development in the control group 77% and in the experimental group 47%. The mean SEM scores at baseline for the control group was 0.88 and the same for the experimental group. But at the end of the study, in the control group, the mean SEM score was 0.98 and in the experimental group it was 0.49. What Sorsha identified was that the odds ratio of SEM pressure ulcer development was 0.26, indicating a 74% reduction in the risk of SEM-PU in the experimental group. And then she found that the mean difference in the SEM delta was 0.49 in favour of the experimental group. So significant, important results here. One is that you can reduce the SEM delta if you intervene when you detect it. And 2, you can reduce the risk of developing the SEM-PU. Very few people actually developed visual pressure ulcers, but the key important result here is the changes in the mean SEM delta scores over the study period, indicating that SEM is picking up an inflammatory response. When you intervene, this inflammatory response reduces. So where does that leave us then? So our key findings are that all visual pressure ulcers are preceded by an abnormal SEM delta. The mean time to pressure ulcer detection is 6 days earlier using subepidermal moisture measurement versus visual skin assessment. Individuals with high and low mobility develop abnormal SEM deltas, which indicates that movement alone is not protective in many individuals. And we need to be able to understand an individual's response to pressure and shear rather than focusing on risk itself. Not all abnormal SEM deltas result in abnormal visual skin assessment. And this makes sense because when targeted interventions are put in place based on the results of the SEM reading, there are statistically significant reductions in the mean SEM deltas, meaning that we won't develop visual skin damage because we have reduced that inflammatory response. So thank you very much.
Hello everybody, thank you for being here and interested in the Stop Pressure Ulcer Day event. My name is Dr. Pinar and I'm a postdoctoral researcher in Royal College of Surgeons in Ireland. I would also thank to Dr. Aglecia, Budri and SWaT researchers for organizing this event. In this presentation, I will talk about our systematic review results, which is related repositioning for preventing pressure ulcer, and I will briefly talk about our clinical review results, which is related prone position with COVID-19 patients and prevention of pressure ulcers. First of all, my colleagues and I would like to declare that we do not have any conflict of interest for this presentation. So let me give you some background. Pressure ulcers can be prevented by determining those who are most at risk and implementing effective prevention strategies such as patient repositioning. One of the important components for prevention of pressure ulcers is repositioning of patients with limited mobility. In my experience, maybe you have also, some nurses assume that repositioning is straightforward and that the correct way to go about it is obvious. But in fact, it is a complex process and has a significant impact on patients. Repositioning of individual is undertaken to reduce the duration and magnitude of pressure over vulnerable areas of the body and to contribute to comfort, hygiene, dignity, and functional ability. However, few writers have been able to draw any systematic research into repositioning, so we have still some uncertainty, some questions around this subject matter. So we wanted to assess the effects of different repositioning regimens on pressure ulcer incidence. We interest in the adult individuals, while our primary outcome was pressure ulcer incidence. Our secondary outcomes were patients' preferences, ease of use of the method of repositioning, nursing workload, which is related repositioning time, costs associated with implementing positioning regimens. We included published and unpublished randomized control trials, colostomy randomized control trials, non-randomized control trials, prospective pre-post studies, interrupted time series studies. We excluded all other types of studies. There was no language or date of publication restrictions applied. And in our method, two authors independently assessed the study quality without blinding to journal or authorship. For this, we use Cochrane collaboration tool for assessing risk of bias. And this was incorporated into an overall grading of the evidence related to each of the main outcomes by using grade. Meta-analysis statistical synthesis was undertaken using review manager. Relative risk and 95% confidence intervals were calculated for dichotomous outcomes. Mean differences and 95% confidence intervals were calculated for continuous outcomes. Results of comparable trials were pooled using the fixed effect or random effect model. Heterogeneity was investigated using the I-square statistics. As you can see on the right in PRISMA flowchart, we included from a total 530 hits, we included 16 studies. The mean sample size was 690, and in terms of geographical location, majority of the studies came from United States, and the studies conducted between 2004 and 2018. Of the included studies, 10 employed randomized controlled trials. One was a prospective cohort study, two were before and after study, one was a descriptive correlational study, and final one, pre-post intervention evaluation study. Risk of bias assessed according 6 domains. As you can see, all included studies were at risk one or more domain. In terms of blinding of participants and personal, which is related performance bias, was poorly reported because it is difficult to achieve in wound care studies blinding participants or wound care givers. Our first comparison was more frequent turning versus usual care. In this comparison, our first outcome was pressure ulcer incidence. As you can see on the frost plot, 8% pressure ulcers developed in the more frequent repositioning group and versus 13% less frequent group. In terms of odd ratio, if you often turn the patient versus less often turn, 25% less likely you get pressure ulcers. However, using grade, the certainty of the evidence has been assessed as low. In the same comparison, in terms of nursing time spent on repositioning, the shortest time we found was in the Manzano et al. Study that was 11 minutes for 4-hour returning 30-degree tilt. The longest time was reported in Polden et al. Study that was 102.8 minutes. That was for 2-hourly turning. In the same comparison again, in terms of cost of nurse time for repositioning, the minimum cost was €6.54, which was reported the Mayer et al. Study that was for hourly turning, and the same study reported also highest cost of nurse time for repositioning, which was €37.08 for 2-hourly turning. Our second comparison was repositioning system, which we mean with this turning device, versus standard of care. In this comparison, our first outcome was pressure ulcer incidence, and we found that pressure ulcer incidence was 2% in the repositioning system group and 6% in the usual care group. And we found there is no statistically significant difference between the study groups. And also in terms of cost in the same comparison, Edgar reported that the costs were dollar amounts calculated for each stage of pressure ulcer. The turn on investment was calculated by comparing the cost of hospital acquired pressure ulcers and the product after the intervention with the cost of hospital acquired pressure ulcers before the intervention. The intervention was found to be cost effective with an estimated return on investment of $16,911. And also in repositioning system comparison with standard of care, in this comparison, we look as an outcome nurses and patients' preferences, comfort, and acceptability. In POWER study, it was reported that no nurse injuries were reported. In the Demir et al. Study, it was found that most of the patients using the repositioning system indicated that they were lying comfortably. Edgar used the Borg scale for evaluation of effort and exertion, ranked on a scale from 6 to 20, where higher scores indicate greater exertion. Less effort was reported using the repositioning device compared with standard of care. And the mean exertion score when manually repositioning patients was 88% greater compared with the mean exertion score using the repositioning device. Our last comparison was turn team versus standard of care. In this comparison, our outcome was pressure ulcer incidence. 11% pressure ulcer developed in the turn team group and 20% usual care. When we look in terms of odd ratio, if you use turn team 50%, you get reduction development of pressure ulcer. However, again, using grade, the certainty of the evidence has been assessed as low. In terms of repositioning and complications, in Manzano et al. Study, it was reported that device-related adverse, which is related mechanical ventilation events, was significantly more frequent in the 2-hourly group than in the 4-hourly group. There were no differences in unplanned extubation or in the endotracheal obstruction. Also, in POWER study, no nurse injuries were reported for repositioning with standard of care versus repositioning system. So what does this show us? More frequent repositioning, which we mean with this, range from 2 hours to 3 hours. And this was compared to less frequent repositioning, which was repositioning every 4 hours or less often. Fewer pressure ulcers develop in the patient's turn 3 hours or more frequently. Fewer pressure ulcers develop in patients with use of turn team. The certainty of the evidence was low because of multiple areas risk of bias within the included studies. However, there were a large number of patients included in the studies, and achieving a lower incidence of pressure ulcers, which is clinically relevant finding. And the results of this systematic review indicate that no nurse injuries were reported with use of a repositioning system. Patients reported that they were lying comfortably with the repositioning system, and nurses exert less effort when using the repositioning system. So it can thus be suggested that repositioning system may provide comfort for both patients and nurses. From now on, I will moving our second paper around this subject, which was published in Journal of Wound Care with the title Prevention of Pressure Ulcers Among Individuals Cared for in the Prone Position, Lessons for the COVID-19 Emergency. You can access full version if you're interested in this topic. I will briefly talk about our results in this presentation. Our aim was in this clinical review to identify and review evidence-based recommendations developed to facilitate the selection and application of preventative interventions aimed at reducing pressure ulcer development in patients ventilated in the prone position. And in this clinical review, we discussed the evidence that points to 3 types of preventative interventions that can be used with patients treated in prone position. First one, skin assessment and management. Second, using pressure redistribution, support surfaces or positioning devices. And final one, use of dressings for prevention, including in the prevention of medical device-related pressure ulcers. Within the first type of intervention, skin assessment and management, our recommendations as follows. First, clinicians should frequently assess common risk areas for pressure ulcers when patients are in prone position. To facilitate a thorough assessment, medical device should be safely removed, if possible, without interfering with medical treatment during patient positioning, and it should be done before prone and after supine positioning. Also, it is essential to keep the skin clean and moisturized. Although it is preferable to use pH balanced cleansers, there is inconsistency in terms of the evidence to support the type of moisturizer. Our second intervention was using pressure redistribution, support surface or positioning devices. Our recommendations with this intervention was individuals placed in the prone positions are at increased risk of developing a facial pressure ulcers as well as pressure ulcers on other weight-bearing areas of the body. The current evidence suggests that positioning devices to offload pressure points on the face and body are a useful addition with an overall pressure ulcer prevention strategy. And our last intervention was prevention and management of medical device-related pressure ulcers. Our recommendations were simple changes in posture of the individual and in the positioning of the device may be used to minimize pressure and shear. And the regular use of protective coverings such as hydrocolloids, transparent film, and silicone in the management of individuals in the prone position may be of benefit in decreasing facial skin breakdown. So as a conclusion, given the importance of pressure ulcer prevention in this cohort of patients, adapting a focused prevention strategy, including skin assessment and care, offloading and pressure redistribution and dressings for prevention may contribute to a reduction in the incidence and prevalence of these largely preventable wounds. I hope you find these results useful. Thank you very much. And I would like to invite you to attend to our Q&A section.